So the problem with Barrett's esophagus is that because it's precancerous, right? So then it could lead to esophageal cancer. Okay, and at that time, if someone has esophageal cancer, and if they can't treat it with just radiation and chemo, what are they gonna have to do? They have to remove part of the esophagus, right? And so what does that mean? If it's, you know, a small part that they can't anastomose, they're probably just gonna have a G2. They won't be able to eat this way anymore. Not that I know of. I don't know. That's the good thought process. I don't know if when I was working, I maybe I wasn't exposed to it when I was working in GI, but you know, it's possible that now would a lot of the science, you know, that they could probably do that. Okay, so those are the esophageal issues that could happen. So now let's go to the stomach. And then I'll come back to the esophagus for something else later on. So in the stomach, there could also be inflammation, right? So inflammation of this entire stomach here. And we'll talk about what causes the inflammation in a minute. Like we have the etiology for the LES. So when there's inflammation of the stomach, that is called gastritis, right? Now let's classify that. Okay, so then let's talk about the causes of inflammation of the stomach. We kind of had talked about earlier in the kidneys about some medications that kind of do the same for the stomach because they're prostaglandin inhibitors, right? So let's classify them for first medications. So can you give me some medications because of their action could cause inflammation of the stomach? So NSAID because it's what again? Prostaglandin inhibitors. NSAIDs are prostaglandin inhibitors. And why is that? Because your lining of the stomach is lined with prostaglandin. So when you give a prostaglandin inhibitor, such as an NSAID, what does NSAID stand for? Non-steroidal anti-inflammatory drug, right? So what is stronger than an NSAID? Steroid, because that's a steroidal anti-inflammatory drug, right? So both steroids, and we talk about cortisol, like endogenously during stress, right, can cause this as well. But as far as medication-wise, NSAIDs and steroids, they are both prostaglandin inhibitors, and so they destroy the prostaglandin, and then therefore it causes more irritation in the stomach. Okay. And then I wanted to add for the OB group indomethacin here, because indomethacin is also an NSAID, but it's a stronger NSAID, and you will see that because of its prostaglandin inhibition, you'll see that in OB. Okay, in premature contractions, we use that. Okay. And then, of course, apart from medications, what else will cause gastritis? What about food and drinks? Yeah. Spicy, what else? Sour, right? So basically acidic, right? Acidic foods, coffee, because of, so acidic will include like coffee, soda, yeah, well, that's not food, but yes. Your stimulants, your Red Bull and stuff like that, that causes acid. Energy drinks, thank you. Don't want to like single out a brand. Energy drinks. And then I was gonna say something else here. There. They have soda, energy drinks, your alcohol, thank you. That's what I wanted to say. Yeah, spicy, sour foods can do that. And then your greasy food really doesn't cause reflux, but it causes nausea. And that's why we avoid them in gastritis, because in gastritis, you already have nausea. And that's why you avoid the greasy food. Okay. So, and then again, we talked about stress, right? As because of the cortisol. Which is your steroid as well. Okay. So let's talk about signs and symptoms of gastritis. So what kind of pain is this patient going to have? Sorry, where is the pain that this patient is going to have? Epigastric pain. Okay, worse when? With meals, good. Epigastric pain worse with meals. And then I will already mention nausea, right? Or even vomiting sometimes, right? Bloating, like if like a subjective feeling of like they're bloating, or they'll say, I'm having an indigestion, right? Okay. So those are that signs and symptoms. So if someone has gastritis and they have a weak LES, so then that gastritis can also cause GERD. Okay, if they have a weak LES already, okay, with the gastritis. Oh, we forgot to mention smoking. So we'll just say, oops, I'll add here ETOH and smoking. So nicotine, really. So then the same manner that there's complications of GERD, there's also complications of gastritis, right? If that inflammation becomes so bad, then the wall of the stomach is going to erode, right? And that is called peptic ulcer disease. Okay. So how do we know that someone has peptic ulcer disease versus just gastritis? So we'll start with so the gastric pain may be more so severe epigastric pain. They still have the pain, they'll still have the nausea, vomiting, right? But also with meals for this one. Okay, with meals. But now we're gonna start looking at their stool, right? So the stool is gonna be positive for guaiac. What does that mean? Or called FOBT, right? So what does this tell us? They have hematochezia. Okay, what is hematochezia? They have microscopic blood in the stool, okay? Microscopic blood in the stool. Up here, they may have with vomiting, right? They may have, as far as their emesis, it's not going to be hematemesis, okay? Not for PUD. It will be coffee ground emesis, okay? And why is it coffee ground? Because it's a mixture of like broken down pieces of like some blood plus the acid. Okay, so it's old blood plus the acid. That's why it's coffee ground. Okay. Blood plus acid. Okay. Now, if this becomes really severe, right? If they have an upper GI bleed that is getting really bad, then they might have melena. Okay. So before they get melena, they will have a positive guaiac or FOBT first. Okay. So what is the difference? Melena is black tarry stool. So this means that this is gross blood, not gross as in yucky, but gross as in a lot of blood, a lot of bleeding. Okay, so this is a large amount of bleeding coming from the upper GI. And we know it's upper GI because it's black. If it's coming from the lower GI, it'll be red. Okay, so upper GI is black. And then if, so before we get to what else could happen from here, let's talk about another cause of gastritis and peptic ulcer disease that is not caused by food or drinks or medication, which is H. pylori. H. pylori, Helicobacter pylori. Okay, so this is a bacteria. Where do we find these? The H. pylori. Where do we find it? Contaminated food or water. Where do we find contaminated food or water? So who's at risk? In the United States, immigrants, those who suffer from homelessness, okay, because they could be getting like food and water from, you know, wherever, right? Those who may be like camping, you know, lakes, rivers, stagnant water, right? More kind of standing water. Okay. Vendors, street vendors. Okay. Because we don't know now, not any street vendors with H. pylori, and who are so immigrants again, right? Or travel to developing countries where there is H. pylori in the water, right? That's why you don't drink tap water when you go to developing countries, South America, Asia, yeah, pretty much East Russia, maybe. You don't want to drink tap water, okay? Because they may have H. pylori in them. It's treatable. It's just the treatment, you know, is intense because there's like 4 antibiotics plus 2, you know, stomach medications, PPI, that you take for about 6 weeks every day. Flagyl, Keflex, or Cipro every day. Okay, so that will cause gastritis, okay, peptic ulcer disease, okay, and we haven't gone to the duodenum yet, but we will now since we talked about it, but also duodenitis, that really leads to duodenal ulcer. Okay, so there's not a lot of people who will get duodenal ulcers. commonly it is your H. pylori patients, okay, or your ETOH patients. Okay. Now, how can we differentiate duodenal pain from epigastric from PUD from duodenal ulcer? There is severe epigastric pain, not with, but after meals. Okay, that is it. Because the upper GI bleed may still include the duodenum. So there is still going to be the same bleeding signs. Okay. I'm going to veer off here for a minute and talk about gastritis a little bit more in the context of chronic gastritis. So if someone gets chronic gastritis, and again, who gets chronic gastritis? Any of these guys that are chronically using what they're using, right? Especially your ETOH, okay? Especially your ETOH. So when someone has alcoholism, then they're chronically irritating their stomach, right? And when they're chronically irritating their stomach, then they're destroying their, thank you. Where is the intrinsic factor? In the fundus. Okay, in the fundus. Okay, so what if the intrinsic factor is destroyed? What is that for? I kind of mentioned it earlier already, right? It is important in the so then no absorption of vitamin B12. Okay. And if there's no vitamin B12, then there is less nerve health. Okay. Initially, that's one of the first symptoms, right? And so if there's less nerve health, then your patient's going to complain of paresthesia. Okay. Let me come back here, and this will become vitamin B12 deficiency. Okay, so when there's vitamin B12 deficiency, one of the complaints of your patient is paresthesia. Now, B12 is also important in less B12 in RBC production. And so this causes what is called pernicious anemia. Okay, and I'm going to go back here, and then this causes a megaloblastic cell, and that is called pernicious anemia. So these terminologies you will see in 242. Okay, when you go to hematology. Okay. So there's that connection between pernicious anemia and chronic gastritis. Okay. Now, who else gets paresthesia and vitamin B12 deficiency? Apart from these chronic gastritis patients, let's just add it here. So if you have a patient who is morbidly obese, one of the interventions for morbid obesity is gastric bypass, right? So they get a gastric bypass. Guess what part of the stomach they're bypassing? Exactly. So the fundus. So it bypasses the fundus where the intrinsic factor is at, right? And intrinsic factor. So therefore, there's no vitamin B12 absorption. So your gastric bypass patients are going to have vitamin B12 injections for the rest of their life. And so their blood is also going to need to be checked for pernicious anemia. So while we're on pernicious anemia, let's go ahead and look at some keywords that you guys might need word association wise for your test taking strategy. So signs and symptoms of pernicious anemia, we already talked about paresthesia, but I want to point out once again that that is not a sign of anemia. That is a sign of vitamin B12 deficiency, right? Paresthesia, but you will see that as a keyword in pernicious anemia as well. And we also look at beefy red tongue as another keyword that you guys might see in tests. Okay. And again, that word megaloblastic, because that is what happens. So megaloblastic, if we're talking about it in hematology, basically means that, so megaloblastic, I'm going to put here just a little bit of hematology. When we say megaloblastic, and we know that this is an anemia, right? So that means that your RBC, your hemoglobin is low, right? And your MCV is high. Okay, MCV is mean corpuscular volume. This has to do with the size of the RBC. And so because it's megalo meaning enlarged, right? So this is a megaloblastic cell where the MCV is high, meaning the cell is larger than it should be because of the missing vitamin B12 inside. Okay, so as far as values, this is what you're going to look at. Okay, in pernicious anemia.